You're listening to Brand Enabled, the human stories behind branding. This is the place to gain greater insight into the human side of branding. Join Gabriel Cohen as he sits down with branding experts, sharing real-life stories of how they faced complex issues along their journey. Learn how others are dealing with maximizing the power of brand and get valuable advice straight from your peers. Here's your host, Gabriel Cohen.
So welcome to today's show. Today, I'm delighted to have Matthew Pinzur with us. Welcome, Matthew. It's a special edition today, which we're calling the healthcare edition, which means that people are going to be super interested, or some people are just gonna stop listening now. No, don't do that. Please don't listen. This is a really interesting story and very applicable to whatever industry you're in. Welcome, Matthew.
Thank you so much. Yeah, we talk about healthcare as being a low-interest sector from a marketing perspective. And one of the things that I do on the side is I teach healthcare marketing at the University of Miami. And I always have to explain to my students, especially the undergrads, that there's nothing we can do that's going to make somebody who's driving on a Sunday afternoon think, you want to know what? I just saw a billboard. Instead of going to the farmer's market, I think I'm going to go get a kidney transplant.
Yeah, and I think that's a good setup for a lot of what we're going to be talking today. But because healthcare is so local and you're going to have people from across the country or even globally listening to this, we're often aware of our local healthcare institution. But talk to us a bit about, just give us a bit of background on Jackson Health.
Sure. Jackson Health System is the major academic hospital system here in Miami. So we have an unusual structure in that we're part of Miami-Dade County government. So we're taxpayer owned within the structure of county government. We're also independent of, but very closely affiliated with the University of Miami Medical School. So that means, especially at our flagship campus just north of downtown Miami, it's a real international destination for things like organ transplant, one of the largest organ transplant programs in the country, neurosurgery, spinal rehabilitation, newborn intensive care, and complex pediatrics. At the same time, because we are government owned, we are a true safety net provider. And in our charter, and in fact, in county ordinance, we have a requirement to provide the same level of clinical care to every resident of Miami-Dade County. That's regardless of immigration status, of health status, of insurance status, of financial status. We like to say that here at Jackson, everybody comes in through the same door. We're a large system, one of the largest public hospital systems in the country. We've got 7 hospitals. We just a couple of weeks ago opened our 6th urgent care center, about half a dozen primary care clinics. So really a very, very extensive footprint, but limited entirely to Miami-Dade County. So all in all, about 70,000 discharges a year, about 300,000 outpatient physician appointments, about another 300,000 emergency room visits, and then lots more when you start talking about things like x-rays and CT scans and everything like that. 15,000 employees, and about 1,100 physicians in training, residents and fellows, which makes us also one of the largest academic programs in the country.
So we're going to get more into the Jackson Health brand evolution story, but how did you get from, you started as a journalist and now you're a chief marketing officer. How did that happen?
Mostly by accident. As you said, I was a newspaper reporter for about 10 years, mostly here in Miami at the Miami Herald. I took a brief detour into government and I worked for the county manager and the mayor in Miami-Dade County. And as my 3rd year there was wrapping up, our health system, Jackson Health System, was really in financial crisis. And the question around Miami was not whether Jackson would survive. The question was when Jackson was going to close. The system was losing about $90 million a year. And if it wasn't for the full faith and credit of Miami-Dade County, it would have been a bankrupt institution. This was the beginning of 2011. The mayor and the county commission made a decision to kind of give it one more go to try and make this work. and reconstituted the board of trustees here into something much smaller and a little bit more focused, and then did a search for a new CEO. And they ended up recruiting a really amazing leader named Carlos Magoya. And Carlos's backstory is fascinating. He had spent almost his entire career as a banker. He had started at a small bank in Miami where he was going to work as a part-time teller for 6 months so that he could pay his way through community college down here. And instead of staying for 6 months, he stayed for a little over 40 years. He got promoted a few times, helped lead that bank through a whole bunch of mergers and acquisitions. And he retired effectively as the chief operating officer for Wachovia and helped negotiate that sale to Wells Fargo and retired before he was 60. I got to know Carlos because while I was working for the county government here in Miami, he was doing 1 year essentially as a volunteer city manager for the city of Miami to try and stave off bankruptcy there. And really took this job as the CEO at Jackson when many people told him it was an unfixable situation. And he did it because he felt it was a way he could start to repay everything that he felt Miami and the United States had done for him as a Cuban exile. And in fact, when he was much younger, in 1978, his younger son's life was saved at Jackson. He was born weighing 1.25 pounds and given just a 1% chance of survival. And we joke that other than having become a banker like his father, that he's now perfectly healthy. And, it was experiences like that that really drew Carlos to take on this challenge. Well, he and I knew each other a little bit. He knew I was ready to move on. And he said, what if you just come for 6 months and work at Jackson? Come on my transition team. You've got some good community relationships. You can help with some of that stuff. I had no marketing background. I had no marketing experience. And now 12 years later, we joke that he keeps forgetting to fire me and I keep forgetting to quit. But it's really been an amazing ride. From the minute that we got here, we knew that the clinical care at Jackson was very strong. It wasn't something that required a wholesale rebuild. It was everything else here around the operations and the finance that really did, to say nothing of the branding. From the first year we got here, we stopped those losses and we started bringing the budget into the black. And it's been that way every year for as long as we've been here. Because of the way we're structured, there is no profit. Every dollar that we make goes back into either expanding our programs, expanding our facilities, supporting our employees. And that means that there's always a challenge of making ends meet. But it also means that the people here are really driven by that mission to the community and by that belief that everyone deserves that same really high level of academic medical care.
So what were those, talk to us about the different phases that you've gone through then as you think about that, the 12 years that you've been there and the evolution of the brand and how the priorities that you set and I guess the role that marketing and brand played in this turnaround story.
The first few years were really just about firefighting. We say only half jokingly that anytime we would go to fix one problem, we'd trip over 6 others on the way there. And probably the hardest thing we had to do, both from an operational perspective, from a human perspective, and certainly from a brand perspective, is the health system was wildly overstaffed for the number of patients that it was serving. Again, it was not about profits because we're a nonprofit government organization. But we had somewhere on the order of 10,500 employees. And really, based on the number of patients who were choosing Jackson, there just wasn't enough clinical demand or enough revenue coming in to support that model. And we had to do a layoff. And we thought it was probably going to be about 5 or 6% of the staff. By the time we went through it, it ended up being closer to about 12%. And we were down to 9,000 employees. And that was all done through a very intentional process where the first thing Carlos did was turn over about 80% of the leadership team. He said, what I'm not going to do is start doing layoffs of the staff with the same leaders that brought us to this situation in the first place. He went and found new leaders. And then he said, I'm not going to do an across the board cut where I tell you it's got to be 5%, it's got to be 7%. You've been brought into this organization because you're an accountable and responsible leader. You tell us what you need to do the demand that's coming in today. And we also then want you to own it. Don't go to your employees and say, well, corporate is telling me I have to do X, Y, and Z. This is going to be your plan. You're going to own it.
So that's
we ended up going down.
Sorry, go on.
Go ahead. No, please.
No, I was gonna because we're in Colorado. I was going to make a joke. So this is where Coach Prime got his strategy from.
Right. Exactly.
Around replacing 80% and replacing the leader. But it is interesting how it's a leadership lesson that can be applicable to different industries as well. Like there are some parallels, right? The Buffs were a 1-11 teams. There's this. For anyone who doesn't understand college sports, the CU had a football team that was 1-11 last year. They brought in Deion Sanders as the new coach, and the first thing he did is he told the players from last year, said 80% of you are going to go because we need new people. It sounds very similar. You were like a 1-11 team.
That's exactly right. The thing that I think was so unusual about it and differentiates it from the sports analogy is our players were by and large doing the right thing, right? It was the coaching staff. It was, if you were talking about a pro team instead of CU, it would have been the ownership. It would have been management, right? That's where the change needed to start. And I very clearly remember having a reporter ask me, when the economy turns around, are you going to be able to hire these people back? And we said, you understand, this isn't about the economy outside of our four walls. This is about what's the demand inside of our four walls. If we do our jobs right, more people are going to choose Jackson over our private sector competitors, and that's when we're going to hire people back. And indeed, that's exactly what happened. And today we're at 15,000 employees.
Yeah, and I imagine then when you started, the brand perception of Jackson Health was really low, and it probably went down even further after those round of layoffs. Not like people saying, oh, okay, we understand that we need to turn it around. It was like if you're there as that's funded by the public, now you're making a lot of people redundant. So what did that mean for what you were sort of doing from a brand and marketing standpoint? Like what did you start, what did you stop or have to immediately start doing differently?
From a perception perspective, the only thing we had going for us when we started in 2011 is that the brand couldn't have gotten much weaker. We say, again, only half jokingly, that the perception around this community was you go to Jackson if you're too sick or too poor to go anywhere else. Because the only thing we were doing at the time was indigent care and highly, highly, highly specialized care. And in fact, I think even a lot of people who were working here at the time would admit that while the individual nurses and doctors and techs all wanted to do the right thing, the culture of the patient experience was, you're here because you have no choice. We'll get to you when we get to you the way we want to get to you, and you'll like it. It was still a very dated approach to consumerism in healthcare, and it was probably 25 or 30 years behind even then. So the first thing we did from a very tactical marketing perspective is we almost zeroed out the marketing budget. What we said is it doesn't make sense to have a full page ad on page 3 of the Miami Herald when page 1 is talking about what a disaster it is over here, right? So even if we could have afforded a substantial marketing budget at the time, we had so much earned media coming at us. And again, put yourself back in the mindset of 12 years ago, where local newspapers, local TV news had much more credibility, had much more reach, had much more influence, right? That was really radically impacting the everyday clinical experience of people's decision-making. The Miami Herald would report that literally Jackson was on credit hold with its suppliers, and patients start thinking, well, if I go there, are they even going to have what I need to get my care? So it was really an intensive couple of years of demonstrating that we could do almost the creative destruction that needed to happen in order to get to a better place on the flip side.
Yeah.
And I think there were kind of two sentinel events that let us know that we had reached the end of that first phase. The first one was a very macro event of, as you can imagine, having lost hundreds of millions of dollars in the 5 years before we got here, there had been no capital expenditures, not just no expansion as Miami-Dade County geographically grew, but no upkeep of the existing facilities. So we said the only way we're going to be able to catch up is if we go to our voters and we essentially ask them for additional money. And we asked them for an $830 million bond repaid via property taxes. And our pollsters had told us at the outset, if everything breaks exactly right, if you really work your tails off, you might be able to get 51% on that. By the end of it, we were at 65% on election day. And it's because we were able to get past the perception of what was happening now at Jackson, now back in 2013 when this happened, and tap into the deeper feelings that people had about having a place this comprehensive, this academic, with this kind of a mission, and what it meant to them as part of their community and even as part of their own family, right? If they hadn't been treated here, they have an aunt who was treated here. They have a grandmother who was treated here. They have a sibling who was treated here. And in a community where so many people are immigrants and exiles, right, the idea of having a publicly funded here for everyone high quality institution really resonated. So when that passed with 65%, which was a massive branding and communication effort where we within the hospital, having to stay apolitical, were doing our part to just factually tell the story of what was going on and to try and, within the bounds of what was appropriate, stay coordinated with the campaign that was out there advocating for it. So that was definitely point one where we knew we were at a new place. I said, that's your macro one. Then there was a micro experience that we had that was a real game changer. As you can imagine, bringing in a CEO who had no healthcare experience, who had retired before he was 60 quite comfortably, bringing him in rubbed a lot of bedside caregivers the wrong way. You know, that is not someone who they're necessarily going to outset see as a leader.
Right. Almost, I mean, it almost feels anathema to healthcare overall, that it couldn't be more further from the truth. You know, financial exactly right. To healthcare, it's the polar opposites.
Exactly right. And he took a huge pay cut from what the prior CEO at the health system had been making. But what he did ask for was, if Jackson is able to be in the positive financially, that he wanted a gain sharing, you know, a bonus structured around that, which people happily gave him because nobody believed it was possible. So we had a lot of employees who believed at the time that all of those layoffs were not about structurally making the health system more able to compete, but about lining his own pocketbook, right? It was a very tense time. About 90% of our workforce is unionized. And while today we enjoy a very collaborative, strong working relationship with all of our unions, that's not how it was the first year. So the way that we knew we had reached an inflection point was when Carlos was doing one of his quarterly town hall meetings. Every quarter in those days, we would go to every one of our hospitals and invite all the employees. We'd talk about what was going on, and he would take questions for as long as people had them. And we were at one of our suburban hospitals, and two of the union stewards asked if they could say something in front of everyone before the meeting began. And Carlos looks at me, and I look back at him, and we're sweating a little bit, but we said, sure, of course, go ahead. And they got up and they essentially said in so many words, you came in a couple of years ago and you told us you were going to make these kinds of cuts and you were going to impact us in this way, but there was a light at the end of the tunnel and that your responsibility was to get us there. And we didn't believe you and we fought you every step of the way. And it turns out we were wrong. You did what you said you were going to do. And we want you to know that we're here. We're on your team. You know, we're moving forward together. I've worked for the man for 12 years. I've seen him cry 3 times, and that was one of them. So we knew that that's where we were at a point where at least we were one team rowing in one direction, even if the waves were coming against us. So you asked kind of what was that turning point? Those were the two things where we knew that now we were out of firefighting mode and we were kind of into a rebuilding mode.
And when you were going through that first phase of trying to really define, okay, what is our position, right? What role do we play and our importance? to the community, to the public. That sounds very much almost like initial having to do position. And you talked about it in very sort of functional messaging. Were there certain messages or articulations of that story that really broke out of people that people understood?
Yeah, I think there were two kind of parallel paths that we took towards that. One was really helping everybody, especially among the leadership team, understand that storytelling was probably going to be more effective here than hitting people over the head with numbers. You could tell them, well, we've got this efficiency rate now and we've saved this much money. That's not necessarily the way that you're going to change perceptions or that you're going to create affinity and loyalty. So a lot of it was about finding those patient success stories, getting them to be our storytellers out in the community. And as we were going around the community, whether it was talking to our own employees or talking to those voters before that referendum, was really creating opportunities for them to tell us their story. And inevitably, if you were in a room with more than 10 people, at least one person had a jaw-dropping story about something that Jackson had done for them. That was a really crucial element of kind of turning around the way people thought about it. And the second part was we had to practice radical transparency. For better or for worse, Florida is a state where government agencies, which we are technically, has incredibly liberal public record and open meetings laws. If it doesn't have personal health information on it, if it doesn't have something else that is specifically excluded, everything is in the public record, which means that, if a reporter wants every email that I've ever sent to the CEO, other than redacting the things that might be violating HIPAA or something else, they're entitled to all of that. For a lot of public systems in Florida, they see that as an impediment. We tried to steer into that, and we said, how can we use that to our advantage? Well, the way we can do that is we can invite reporters in for tours of everything. And then when they have questions, we don't have to sit and make the difficult strategic decision about how much do we tell them, because that's already solved for. So the question is only, do you want to be defensive about it, or do you want to be really upfront about everything? And we prided ourselves, we still do, on being incredibly responsive to those requests, on having experts available, on producing documents, on by and large, when it's feasible, not using our media relations team as a firewall or as a go-between or as a translator, but as a facilitator that helps bring those experts into dialogue with the reporters as kind of the stand-ins for the community we're trying to serve.
I think when we were having a conversation before the recording, you were also talking about this notion that there was opportunity to position yourself also as a bit of a Robin Hood story in contrast to others. Talk a bit about that.
Yeah, it's funny because when we were developing our first strategic plan, as somebody who was heavily involved in writing it, I can tell you it was very long and it was better than anesthesia for putting you to sleep. And Carlos is the one who really simplified it down to 2 sentences. He said, we need to be Dr. Robin Hood. We need to get money from the people who have it so that we can pay for the people who don't. And that served as a really powerful rallying cry that I think in the minds of those nurses, of those techs, of those bedside caregivers, could really help crystallize that the money wasn't about the money. The money was about the mission. I think that phrase, no margin, no mission, is a little bit overrated and is a place where it's easy for some of us to hide some of the more business-minded things that we're doing. But I think helping people whose day-to-day focus is on administering medication and on delivering care and on emptying bedpans, right? Refocusing them on how all of the things that are happening outside of the patient room connect back to what they're doing is a critical part of the internal storytelling. And if you do it right, then it kind of bleeds out into the external storytelling as well, especially when you look at a health system as large as ours. Again, 15,000 employees and their spouses and their children and their parents and their aunts and uncles, right? That becomes the story that is in the community.
And so I think that's a good segue then into the next phase of this, because if the goal is to get the rich people who can pay, now brand and marketing really has to play a much more direct role. I thought it was really interesting when you were talking about the initial phase where you turned all of marketing off, that you said, like when page one of the newspaper is talking about what an absolute disaster we are, then what's the point in us then advertising on page 5 showing like smiley faces? I think that was that's something that really resonates with me. But now having gone over that first bump, how did you make that transition back, and how did you start telling that story?
I think there were 2 prongs to that strategy. So now we're in like 2013, 2014. Prong 1 was, unlike a lot of other hospital providers when it comes to a marketing strategy, we had almost 100% name recognition in our market. We didn't have to do general brand advertising because everybody knew where we were and everybody had an opinion on us. So what did we do? We treated those service lines where people would still choose us. We treated each of those as if they were a separate client and we were an internal agency for them. So that meant some of them needed completely different strategies than other ones did, completely different tactical plans, completely different budgets. And even though we had a style guide that everything was hanging together on, the way that we approached marketing organ transplant or neurosurgery was very different than the way that we approach marketing high-risk maternity, for example, right? So we were very tactical, and it became less about try and change the way you feel about Jackson, right? Which is like trying to boil the ocean. And it became more about when you have this one very specific need, this is the place where you want to come for it. So we really segmented the heck out of that audience, and we got laser focused on figuring out what the right message was for them and how do we immediately generate some kind of call to action out of that. Go ahead.
And so for people who aren't in healthcare, this is where the concept of consumerism starts to come in, because people normally think, well, how do you actually do marketing and branding within a health system where it's not about trying to drive choice or share, but actually when you deconstruct it, there are some service areas, some specific areas where there is choice. Can you just maybe talk just a little bit about that, just to bring a bit of context?
Absolutely. That's such a good point. And it's something that even marketing students kind of struggle to grasp when they first encounter the healthcare space. And it's changed radically in just my 12 years in the business, and is changing still very, very quickly now. And I think a story that sums this up, very early in my time here, I went to talk to the head of maternity, the chief of OB, and I talked about us wanting to do a campaign to get women to deliver here. And he said, that's crazy. Women don't choose the hospital. They choose their doctor, and then they deliver wherever the doctor says to. They listen to their doctor. And I said, I completely understand what you're saying. And if I had come to you 10 years ago and said we should have a TV commercial for a prescription drug, you would say, you're crazy. Patients don't choose their prescription drugs. They take the one their doctor tells them to. And we all then remember what happened with things like Allegra, like Cialis, right? Some of the first ones that were out there doing direct-to-consumer advertising looked crazy at the time. And now we may think it's crazy from a policy perspective, but from a marketing perspective, it's a huge chunk of the healthcare marketing sector. So we're still seeing the evolution of all that. But that also requires a different kind of audience segmentation for different types of healthcare marketing. What do I mean by that? Like I said, Jackson is one of the largest organ transplant programs in the country. But like I said in the kind of the first example that I gave you when we started, nobody decides on a Sunday afternoon they want to go for a kidney transplant. And that's one where patients really will probably have very, very little to do with deciding what hospital they go to for a transplant. Because by that point, they're not working with their primary care provider. Their primary care provider has referred them to a specialist who has probably referred them to a subspecialist. And that's where the patient is putting all of their trust. So from a marketing perspective, our job then is to make sure that those doctors who are making that final referral, right, that nephrologist, that pulmonologist, that's saying, here's where you need to go for a liver transplant, We need to make sure that our marketing is really primarily focused on them. They're the ones who are steering those patients. But we do still have to have, and increasingly this is true, some kind of consumer element to it. Why is that? Because when Gabriel, my doctor, tells me that I need to go to Jackson to get my organ transplant, I better have at least a neutral perception of that brand so that I'm open to that. And I better have the kind of mid-funnel stuff, like the strong website, the strong SEO, the strong reviews, so that when the patient goes and does their own research, which we know is the first thing they're going to do, they can't be so turned off by it that they push back on that referral. So that's kind of one end of the spectrum. We talk about the more something is a niche service, the more something is a medical specialty, the more that balance has to be focused on the referring doctor. The other end of that continuum are things like emergency rooms, urgent care centers, right? Where there probably is nobody who's an intermediary in that at all. You're probably just going to the urgent care closest to your house. So my job is, how can I make you skip the one that's closest to your house and go half a mile further to go to one of mine? Right? How can I make you skip that emergency room that you've been going to for the last 20 years and go an extra 3 minutes to try one of mine? That has a very, very similar approach to whether it's restaurant marketing or streaming services, whatever it is. How does Netflix get you to subscribe to them instead of Hulu? How does McDonald's get you to come to them instead of Burger King?
Well, and the big challenge in healthcare is it's in many cases it's less about trying to skip the competitor emergency room to come to yours. It's don't go to emergency room, go to an urgent care to understand when you should be going to one versus another. It gets even more complex and nuanced.
There's definitely an educational component to almost everything with healthcare marketing. And also one of the things that I've been always interested in learning more about, and in fact, I mentioned that I teach over at the University of Miami. Every week, I ask my students the same two questions in a little poll they do on their phone. I say, on a scale of 1 to 5, how effective is healthcare marketing? And on a scale of 1 to 5, how ethical is healthcare marketing? And the fact of the matter is that the community, whether it's your patients, whether it's your other stakeholders, hold healthcare providers to a higher ethical standard than they will a fast food restaurant or a streaming service. So we get into some great debates in the classroom and in the boardroom here at the hospital system about how far can we go on things which would be considered completely normal for a car dealership. Is it ethical to do that in the context of somebody's healthcare?
And so they're bringing examples in as well. So it's encouraging them to be looking out every week for examples of healthcare marketing.
Correct. And it's for me trying to understand how different milestones along that educational path influence the way they're thinking about it, right? They come in many cases, some of my master's students a little bit differently, but especially the undergrads, they barely come in even thinking of healthcare as an industry, as a sector of commerce, right? They think of it more just as a service. So when they start thinking about it as a business, to what degree are they comfortable with profit maximization, with a revenue goal, with prioritizing marketing services, not necessarily based on what the community needs most, but on what brings in revenue for the hospital system, right? Those things are really knotty and weighty things for somebody to wrestle with at that stage. One of the conversations that we have, I don't think it'll shock anybody who's listening to this podcast, that companies data mine their own customers for loyalty to try and resell, to try and upsell. Well, healthcare providers are starting to do some of the same things. You remarket to your existing patients. These are folks who have already trusted you once. So I always like presenting my students with a hypothetical. We have a pretty robust weight loss surgery program in our health system. Would it be ethical for us to go through our medical records, through our electronic medical records, flag everyone who's in a certain age group where we know that they're good candidates for that kind of surgery, and people who have, a body mass index that makes them unhealthy, at risk for all kinds of complications, and candidates for weight loss surgery? Would marketing to that universe of people be ethical? And we'll have a good discussion on that for 3 or 4 minutes. And, usually it's about a 50-50 split. And then I'll say, okay, Does it make it less ethical if instead of marketing to everyone who meets that criteria, I only market to the ones who have private health insurance where I can profit off of that surgery? Oh, well, that's different. And then we get into a whole different discussion about that. Then I say, okay, let me throw another monkey wrench into this discussion. Because we're a comprehensive health program, do I have an ethical obligation to ask the electronic medical record, have any of these patients ever been treated in my behavioral health service for an eating disorder? Do I have a proactive ethical obligation to think about those things and exclude them from the marketing? So all these kinds of things don't really come up when you're selling a streaming service, but they do come up when you're serving healthcare services. We have a similar discussion about marketing maternity services, right? Do we have an obligation to understand whether women have tested that they can't have children and that that's somewhere that is in their medical record with us? Should we therefore not risk upsetting them by sending them maternity information, right? What if they have had miscarriages in the past, right? On one hand, those might be people who are really eager to try again and have a baby. On the other hand, that could be something that's really emotionally upsetting for somebody, depending on the timing, depending on their... And again, nobody has that conversation about selling soda. But when you put it in a healthcare context, it becomes a much more lively debate.
How do you ever actually make a decision to do something when there is that grade? Because you could always argue that that ethical concern. Can you ever actually do it where, I don't know, if the burden of proof is so high?
It's a great question, and there doesn't seem to be industry-wide any kind of standard approach to that dialogue yet. I'm really lucky for a number of reasons here, not the least of which is the faculty member at the University of Miami who founded their ethics program is also the chair of the ethics committee for our health system and is just genuinely a great guy. So we can bring in him at any time and we can bounce these questions off of him and we can have a dialogue among my staff, among the others on the executive team, and with this really great ethics thinker. And something that he and I have always agreed on is even in these areas where there probably is no right answer or their wrong answer, the mere fact that we're stopping, that we're pausing, that we're having the discussion, that we're second guessing ourselves, all of that makes whatever final decision we come to inherently more ethical because you've gone through that process of thinking about what are your motives for something and how are different people being impacted.
Matthew, maybe in the same way that, there's a lot of former journalists that have become marketers, maybe this whole the growth and importance of ethics and data, now there's a big career path for all of those philosophy majors who are trying to figure out what to do with their lives.
That's exactly right. I was a political science major, so I'm glad I stumbled into something where I can pay the mortgage.
So I want to make sure that we close the loop back on that second half of the story that you started to talk about. Okay, now that we needed to start to attract the people who would be able to pay for the care, and you started to do that across service lines. What worked? What didn't? What lessons did you learn? And then what were the sort of future phases?
Right. So I talked about two parallel paths, and we spent a long time just now going over what we were doing to focus on individual services rather than the brand itself. The other path that we were really taking was trying to, again, steer into one of our challenges, which was even when we felt it was safe to go back into marketing, we never were going to have enough money to compete with the big private systems in this market. Right. Our biggest competitor down here is a private, a not-for-profit, but a private that has plenty of cash on hand. And I like those folks. I respect those folks. I have friends over there. But the fact is, they spend more money in one day as the big sponsors of the Miami Marathon, right, than I can spend all year on my community outreach and sponsorship budget. So what we said is, how do we take advantage of that? Right? How do we not try and beat our competitors at their own game? We can't play the same song that they're playing and just try and play it louder because we can't afford the volume. So what can we do that's off left field? How do we find partners in this work? How do we find people who have emotional attachments to us and work with them on the storytelling? And I'll give you a couple of examples of that. We have some relationships at the public school system here. And something that folks outside Florida might not know is in Florida, public schools are organized county-wide. So Miami-Dade County Public Schools is a massive, it's the third or fourth largest public school district in the United States. So we spoke to the superintendent there, who was a friend of mine, and then we spoke to our partners at the University of Miami, and we said, what if we tried to break the Guinness World Record for the most people trained in CPR in a single day? I will tell you, we did not break the record. I will tell you, we had almost no intention of actually trying to break the record because we couldn't have afforded to bring the Guinness people in to try and audit this, even if we wanted to. But it became a great rallying cry. Everybody loved the idea because no matter how short you fall, you've still got more people trained to do CPR. And we ended up launching CPR Day Miami, and we opened up 6 public schools, the Red Cross headquarters, and the University of Miami campus, with CPR trainers all on a Saturday. And we trained hundreds and hundreds and hundreds of people in the very basics of CPR in one day. It got a ton of media coverage, and we were able to even go beyond just who heard about it through the media because we were just so organically reaching into the community. When we're at your neighborhood high school doing this, right? When we're working with the Red Cross, when we're at the University of Miami, things like that made a big, big difference. We also, another partnership that we did with the school system is we tried to put health and wellness and nutrition tips in a small newsletter. And we did an elementary school version, a middle school version, and a high school version. And the school district said, as long as you pay for the printing, we'll put it in every kid's backpack in the whole school district. Well, that's hundreds of thousands of people we're getting right into their homes. And now they are attaching something positive and constructive to our brand. And we didn't even have any calls to action in it. That was way before we were marketing our pediatric emergency rooms, for example. It was just a way to kind of reintroduce the brand to the community. So we were constantly looking for things like that, as how can we punch above our weight, and how can we use people's natural affinity for this organization and its historic role in our community to make a big difference.
I think there's an interesting generalized lesson in what you just said, which is sometimes the importance for marketing people, brand people, to have a diverse set of experiences. Because if you just work at a larger organization where you can play the scale game or you can play the traditional playbook, to your point, you have to zig when everyone else is zagging. Invention is born by necessity. Creativity is born by necessity, and constraints are good sometimes because they force us to have to adapt and be creative and rewrite the playbook instead of just following the basic scripts. Like anything else that you'd say that where you other examples where you've had to sort of rewrite the playbook, or maybe even talk about how that then connects to then how you address the brand question.
So then I think the last milestone that we reached and the phase that we're in now was really getting a lot more strategic and understanding how our processes impacted the creative work that we were doing. And that's been a journey that we've been on for at least 5 or 6 years now. And some of that was at the very, very basic blocking and tackling, to take it back to your college football reference, right? And one of the things you and I were talking about before this was, how do clients make sure they're well aligned with their agencies? So we put in a very strict and formal timeline that we've now been adhering to for, I think, 5 cycles, where as soon as each of our internal business units, our hospitals and divisions, finish business planning for the next fiscal year, we have a series of meetings with each hospital CEO, each business unit leader, where my staff and our agency are there. And we just say, no forms, no scorecards, no nothing. Explain to us your business plan and strategy for the next fiscal year in your own words. and we sit, we listen, we ask a lot of questions. From there, we make a very high level kind of finger in the wind guess at what kind of budget we're going to need to carry that out, because we're going to be now requesting budget from our CFO at the same time as we're developing a tactical plan for the new year. And most then of our spring and into the summer is spent with our agency and our staff working in concert. And by and large, they are asking themselves three questions. What do we need to stop doing? What do we need to start doing? What do we need to continue doing? And when you ask those three questions, you're putting a little bit more framework around the conversation than just a blue sky, hey, what do we want to do next year, right? You're being a little more responsive to your data because you're seeing what worked and what didn't work, and you're bringing that into the conversation. But you're still leaving things open enough that you're not trapped in we just have to do what we did last year, but 3% more. So those conversations become really important. And in the room for those conversations are folks from those internal clients, right? Maybe not the CEO herself, but somebody who's over business development there, somebody who's over strategy there. They're part of that conversation. And then we have a strict end of that timeline too, which is by the third week of August. Our fiscal year starts October 1. By the third week of August, we are now meeting back with all of those senior executives with a finished, polished proposal, both a full tactical plan, but also a simplified, we call it a placemat, a one-pager that summarizes who the target is, what the new goals are going to be, what the major tactics are going to be. We pitch that to them, and either they sign off on it right there in the room, which happens about 95% of the time now, or they have a couple of follow-ups that they want us to do, to check on, to tweak. And then by Labor Day, our plan is done, and that leaves us with a full 30 days to get stood up for an October 1 start date. So that getting that kind of rigor into our process has been an increasingly important part of it. And there's enough flexibility within that rigor that as the technology changes, as the different ways of reaching audience change, and as our ability to gather and reflect on data change, we still have that structure that makes sure that we're doing things in an intentional way. The way that we then live those plans over the course of the next 365 days is every 10 weeks, we have a meeting that is on the calendar forever, right, that everybody knows about. And a week before that meeting, we send out a dashboard with all the key performance indicators, and we send that original tactical timeline, and we say, hold us accountable for it. And we sit down for an hour and we say, here's where we are. Here's where we expect it to be. Here's what's working well. Here's what's changed in the industry since we did this plan 4 months ago, 6 months ago. What do we all need to be doing? And we leave that meeting with an action plan. So that way, we've really been able to, I think, 98% get rid of the thing that is the bane of a marketer's existence, right? Which is your client coming to you 4 months into a plan and saying, I had this idea in the shower this morning, we should do X, Y, and Z, right? And there's no strategy behind it necessarily. There's certainly no resources identified for it because they don't want to cancel anything else that they've got on the plan. Everybody understands that there are these opportunities in the course of the year to bring entirely new things to the table. And outside of that, we're only making changes when things happening outside of our institution are driving that change.
Okay, so it's a great leadership lesson on how to create internal structure and process. I imagine it probably build the relationship with those internal stakeholders. So they don't see those that might have thought of marketing as a t-shirt and cups department see you as a strategic partner. So
although we do still get a lot of requests for t-shirts.
That was going to be my question. Just to say all of that, doesn't mean that it doesn't happen. So how do you deal with it when it happens? Do you point them back to the product? How do you handle those without naming names?
Some from column A and some from column B. So we make sure that there's enough money in the budget every year that when the client, who does know their employees, know their patients, know their doctors, if they come to us with a request that's relatively modest, it's going to make them feel good, it's not going to do any harm from our perspective, great, let's try and do it for them. Let's find a way to get to yes. right? With everything else, usually what happens is somebody comes to us with a new tactic that they want to do, right? And our attitude is, we're chefs, we're not short order cooks, right? So I understand you want this new plastic card to go behind the ID badge, or you want this new clipboard, or you want this new whatever. In service of what? What are you trying to get to? What are you trying to accomplish? Well, I need employees to remember, this acronym, or I need more patients to be changing their behavior in this way. Okay, great. Now we understand what we're trying to get to. And we can now rely upon not just our own expertise as marketers, but let me show you some data from your service line, from your hospital, right, that shows you why this alternative that we're suggesting is going to be a better way of getting where you want to be. I'll give you a real small, quick, tangible example. People who work in hospital world know that every 3 years, you get a massive survey from an organization called the Joint Commission. It's basically an on-site week-long audit of everything that you do in the hospital from a quality and safety and regulatory perspective. And it's extremely stressful for everyone, because if you fail it, you can no longer accept Medicaid and Medicare, and you're essentially on your way out of business. The stakes could not be higher. And a lot of energy goes into making sure that employees are ready to answer the right question if the surveyor asks it, that they're doing all the right things, that we're up to date on all of our regulations. So we got a request going into one recently. We need a cardboard card that we can hand out to thousands of employees at this one work site that gives them kind of a cheat sheet for some of these things. We said, okay, I understand you're trying to get ready for your big survey. That we built a digital version of this that is not an app. It's just a very simple website. You can have terrible bandwidth wherever you are. The employees can save it to their phone. It's going to look just like an app, and everything is very simple to navigate, easy peasy. And they're like, yeah, that's great. We know about that, but nobody really uses that. You need to understand, we love you guys, but nobody really uses that. We think a paper card is going to be more effective. I said, okay, tell me how many people a month you think use that, how many visits a month go to that online version of it? Oh, it can't be more than a couple of hundred. It's like, okay, let me pull up the dashboard right here while you're here, so I'm not making anything up. Oh, look, it was 15,000 last month, 15,000 visits to that site. Oh, wow. Okay, well, I guess we want to be there. We don't want a paper card. Can you put us on there? Yes, we can. We'd be happy to do that. You get me the information and we'll have it updated by tomorrow.
I love that story. That's a brilliant story. One other thing I wanted to cover is, as you're talking about these strategies and plans, that especially in healthcare, a lot of it then isn't just around the example you just described. It starts to feed a lot into then the actual experience as well. So things that aren't necessarily traditionally owned or run by marketing.
I think the wall between marketing, operations, and what we like to call the patient experience has been eroding for a long time in hospitals, and it's happening faster and faster. And it's probably, you're seeing that in other places as well, right? If you go into a Walgreens or a CVS, a lot about your experience walking through that place is being driven by some of the stuff that's coming out of marketing. It's not just signage on the walls, right? But it's, what is that QR code letting you do? How are you signing up for a loyalty program? So that we can be remarketing to you and better understanding who our customers are. That requires a lot of creativity from the marketers. It also requires a massive amount of humility, right? We need to go into all of these conversations. In fact, we had a big staff retreat. Most of my staff, of course, works remote now. But every 3 months, we all come together. There's about 35 of us now. We come together at one of the hospitals. We spend half a day or a full day together. And one of the themes of the last one is, for the new fiscal year that we're starting here in 2 weeks, I want you to have kind of 2 keywords in mind that feed each other and can drive everything you do, right? One is data and one is curiosity, right? So when somebody comes to you with some off-the-wall request, instead of rolling your eyes and having to trot out the script that you've said 47 times about why we don't do that, let's get really, really curious about why they want that and what they're trying to solve for, and let's meet them on their terms. But let's also not pretend that we haven't been through this 47 times before, because we have that data. So let's use that data to help them accomplish their goals. And then when we're looking at that data, let's get really, really curious about what's driving some of those results. You and I had a conversation before we started recording about an experiment that our digital agency has been doing the last 6 weeks, where in one of our service lines, they've had half of our digital ads written the regular way by their staff and half written by a large language model, written by ChatGPT. And we've seen that the click-through rate of the ChatGPT ads is double that of the ones written by the staff. But it is only half as effective at generating any kind of follow-up action once people do click through, whether that means making an appointment, watching a video, using one of our tools. And you asked me, why do you think that is? And I said, we don't even have a hypothesis yet. Now, it's only 6 weeks old. We have to see if there's any signal in that noise. But that's an example of how the data can drive the curiosity. And then let's use that curiosity to act on it. And then let's look at the data to see what we can learn from it.
I love that example. And how does that then extend into maybe work that you're doing? How do you insert yourself to, you were talking a lot about the facilities, or as we think about consumerism, a lot of it is the experience. Right? You've used some great analogies in comparing healthcare to other industries. And if you think about the most basic thing in healthcare, which is just booking an appointment, right? I know I can order a Starbucks coffee in my app and go and pick it up. I can order something on Amazon and it's being delivered. So you imagine like a busy mom, a busy father or mother trying to book an appointment. And all of a sudden it's like, I have to what? I have to phone and then wait on hold and press 1 and press 2 when I'm in the car. How talk about that piece for a second.
Sure. And that's a great example. Online self-scheduling for healthcare is a little bit of the Wild West right now. And it's a fraught thing because they're accustomed to being able to, go book a movie online, right? To go to the theater and their seat is waiting for them. They certainly don't have to talk to a ticket taker anymore, right? But that's also because they're paying for that movie ticket out of their pocket. They don't have movie insurance where their movie insurance company says which theater they can go to. And by the way, you have to talk to your primary movie critic before you can decide what kind of movie you're going to go watch. Are you eligible to watch Barbie, or are you only eligible to watch Oppenheimer? Right? So it becomes an order of magnitude more complicated. Some systems are more sophisticated than we are. A lot of them are more sophisticated than we are on that front. But what we've started with is if you want to go to one of our urgent care centers, right, and right now it's 2:04 Eastern time as you and I are talking, right? My daughter texted from her middle school a couple hours ago that she wasn't feeling well. I wasn't going to go yank her out of school in the middle of the day and take her to an emergency department. Most likely, my wife or I is going to take her to an urgent care after school. What you can now do with ours is you can say, well, it's 2:04 now. By the time I have her in the car and can get to where the urgent care is, it's going to be 4:30. I can go ahead and lock in a 4:30 slot at one of our urgent cares. And I can do that up to 2 business days in advance, right? So that's something where we know almost anybody who walks in the door is going to be eligible for that service. That's a way that we're trying to create that. Another way, now let's look at the back end of that encounter, right? We've piloted something in our urgent care centers and also with some of our primary care doctors, where when you are leaving your encounter, we're going to hand you a card that thanks you for coming to see us. There's a place for them to write if you have a follow-up appointment on there, but there's also a QR code on it. Scan here to let us know what you thought about today's experience, right? I'm not having that generate an email to the CEO of that hospital or something in some proprietary database. I'm sending them to Google reviews, right? Because I know that a high volume of Google reviews is going to help us. And it's a real incentive to the operations team in that facility. If they know that we are encouraging a public review, then we better be on point with everything that we're doing.
In that example that you said, there are some physicians who might say, why are we getting reviews? I'm the expert. Why do we care what consumers think? Have you dealt? How have you like? Are those real conversations, and have you dealt with those?
We have not had that kind of pushback from physicians, at least not yet. I think they understand that consumerism is where the puck is going, as Wayne Gretzky would say, that a great hockey player doesn't go to where the puck is, they skate to where the puck is going. And the physicians, I think, understand that. I think where you see a little bit more friction and rub is once you get past that urgent care, past that primary care, and you get to things that are a little bit more complex. Like I said, we have not entered the space of proactively pushing for reviews in that area yet. But having talked to some of my colleagues who have, and having this conversation with my students as well, you start to bump up against a real difference between healthcare and almost any other industry when it comes to marketing and when it comes to consumerism, which is when you go to a restaurant, Gabriel, you know whether that was a tasty meal or not. On the healthcare side, people don't always know what a quality healthcare experience looks like. They know if they were treated nicely. They know if they were listened to. They know whether their complaint was solved in that first appointment or not, right? But if you're deciding who to go to for heart surgery, is bedside manner most important? Is ease of getting an appointment most important? Or is having the lowest mortality rate most important, right? What I think we're still struggling with is how do we bring all of those elements into the same conversation, right? How do we get on the same page about the fact that, yeah, you want to know what? The corporate bean counters in the back room like me better be making sure that we're staffing that practice well enough that they do have time to be friendly. They are able to answer the phone. They are able to create those appointments. And also, we have to make sure that that surgeon understands that almost no real world patient who's coming to see her is going to go onto the Medicare website beforehand to look at his PSI scores and look at his mortality rates and all that kind of stuff. They're going to be relying on a whole bunch of other different influences. So you can deliver what a physician would consider great care. And if it's done in a way that is not consistent with what a consumer considers great care, you're going to end up with unhappy consumers. And in a world of consumerism, where we are seeing Google reviews, where we are seeing word of mouth help drive more of that, that entire package becomes really, really relevant to where the business is going to go.
Matthew, this has been a wonderful conversation around sort of brand turnaround story, leadership lessons, trends that are happening in brand and marketing. But I want to end with a sort of what's the current state of the brand? What's next? What are you excited about?
I think the thing that we're excited about and terrified about in equal measure is right now we still are not on a burning platform as healthcare marketers, because the vast majority of the patients that we see in the areas that, to be very frank, make money for all hospitals are still at least somewhat influenced and driven by the same kinds of marketing tactics that were in use 20 years ago. Okay, when you're looking at the average age of people having heart surgery, people getting cancer treatment, people having organ transplants, they're still watching linear TV to some degree. Some of them are still reading newspapers, right? All of that kind of stuff is still very much at play. When I look at the generation that's coming in behind them, the question about how to reach and influence them, we've never had bigger question marks and fewer answers about that than we do today, right? So we're experimenting in that space, right? This is the age of our patients in our maternity service, right? They do not watch linear television. When I ask my students, how many of you have watched TV either over the air or on cable, but not on demand, like at the time something airs? How many times have you done that in the last month? It's 0 to 1. When I say, how many of you have listened to an AM or FM radio station in the last 30 days? 0 to 1. How many print publications do you subscribe to in print? 0. It's just not happening, right? So yeah, I understand everybody's very excited about things like advertising on Netflix and connected TV and influencers and Instagram and all of that. And that's going to have to be a part of what we're doing in the future. but for these big life-changing decisions, right? Or for the person who you trust every single year to go for your annual physical or to go for your mammogram or to go for your colonoscopy, right? I don't think people are going to make those decisions based on an Instagram ad. And trying to understand where is that influence going to be pushed is the exciting and the terrifying thing about where we're going. I would really drive everyone to take a look at some new research that was done last year. That's in the annual trust survey that's done by Edelman. And in their last survey, they asked a fascinating question and they cut the results by age. They said, do you believe that a regular person doing their own research can be as informed on healthcare issues as a doctor? When you look at people who are currently, I think, 55 plus, like single digits, 5% agree with that statement. When you look at kind of the millennial generation, more or less, it was something like 30-something% agreed with that. And then when you looked at younger than that, at the generation coming up behind them, it was, I think, getting close to 50%, right? So when the physician is no longer the voice of authority or the voice that you trust, how does that impact the way that we're marketing and the way that we're telling our story, right? If people don't think that they're getting a straight and honest answer, even from a doctor, then how do we embody our voice?
That's fascinating and terrifying.
In equal measure.
In equal measure. Final question, just to touch on one thing that's this bridge of your personal and professional that you've alluded to a couple of times, which is the teaching piece of it. You've shown, I think, there have been a couple of great examples that you've shown how you use your role as a professor in your marketing class as real-time subjects that informs the job that you do. Can you just maybe talk a little more holistic about what teaching brings? Because you see more and more today CMOs or marketing leaders playing an adjunct professor role. Talk about why you do it, why you love doing it, the benefit that it brings to you, maybe both personally and professionally.
So some of it is purely selfish. It's a great place to tell the Jackson story. It's a great place with the undergrads for us to identify future interns and entry-level staff and to, bring people out of that. But I think a little bit less selfishly, I guess, is putting together a curriculum and having to try and tell an educational story over the course of a semester forces you to ask yourself some really difficult questions about the way that you do your work. So I can't sit there and tell them, here's how audience segmentation works, and here's how brand identity works, and then realize that actually in my day job, we're not living up to any of that. We're being a little bit loosey-goosey about things. We're not being disciplined. We're not following best practices, right? So on one hand, I try and make sure my students are getting the benefit of understanding that sometimes the way the world works is very different than what's in a textbook. Right. But the flip side ends up being true, too, which is my staff and I sometimes need a reminder that some of the things in the textbook need to be applied in the real world if we want to be effective. And it has helped us get more disciplined and more focused over the years.
That's a wonderful story. Matthew, I feel like we could be going for hours, but thank you so much for the conversation and for being on.
It was very much my pleasure. Thanks for having me.
That's all for today's episode. We hope these insights from top brand leaders help you as you face your own branding roadblocks. Remember that you're not alone in the challenges you face, and there are always impactful, creative, and human ways to solve brand problems. If you would like to further connect with fellow elite brand leaders and join our community, send an email to gcohen@monocle.com. Thank you for joining us. See you on the next one.